Covid-19, March 2022. Slide 1, 440 million cases, 6 million deaths. A virus has changed the world. Perhaps 28 million have died. If you look at excess deaths in the last 2 years, not just those with Covid-19 on the death certificate, the death rate is between 1 and 2%. Perhaps 1.5 billion people have been infected worldwide. So have the gods punished our hubris with nemesis. 2. This is my take. After 24 months, a global disaster showing our vulnerability, our coping and our care. The picture still changes weekly around the world. It seemed important to try and gain some perspective by this re-examination at 6-monthly intervals. Slide 3, the virus particle. We know a great deal about this virus now. It's how it manifests itself clinically, how we can detect it in tiny amounts. We can examine the antibody response, the development of immunity, and the precious herd immunity, where 60 to 80% of the population are resistant to the virus. We can examine the virus around the world and detect early mutations and possible implications for infectivity and virulence. There are several coronaviruses circulating. They probably differ in their infectivity and in their effect upon the person. It results in clinical picture, morbidity and mortality. Viral mutations sometimes produce more transmissible or virulent viruses, and there is concern that current vaccines may not be so effective in protecting against them. The speed of vaccine development, the technology of the genome, the trialling, testing and implementation have been extraordinary. Slide 4, countries and Covid-19. These figures certainly underestimate the true numbers, perhaps between 5 and 50%. And the figures are almost certainly higher. This is partly because routine data collection isn't possible in some countries, partly to conceal poor performance and missed opportunity for political reasons. Why have some countries managed better than others? It is complex. There have been mistakes, often strongly contrasting views from experts, and political interference. The USA and Brazil suffered worse. Taiwan and New Zealand got most things right. Ideally, a rich Western country with a well-run and resourced healthcare system would have a 4-week stockpile of protective equipment and piped oxygen supply. There would be an accessible reserve of ICU beds, ventilators, countrywide. There would be a plan in place for such an outbreak rehearsed within the last 12 months and the accompanying resources. There would be a worldwide communication network examining diseases, new diseases, early problems and a time frame of possible spread. Leadership would be transparent, reasons given for action and trust maintained. There would be international cooperation identifying the pathogen, testing for it, sequencing the genome, shared work on vaccines and the clinical manifestations, signs, symptoms, pathology of the disease. Slide 5, countries and COVID. There would be agreed thresholds for lockdown, full or partial, and restriction in terms of working in factories, offices, schools, transport, shops, leisure centres. There would be models of working from home and for remote medical consultation. There would be agreed threshold for border closures for inward and outward travellers, with necessary test and quarantine for the incubation period of the disease. There would be a test, trace, isolate system to identify cases early and isolate and monitor their contacts. There would be financial support for people requiring to isolate for those unable to work, and generous benefits maintained, i.e. free school meals, rent support. There would be agreed powers of enforcement. There would be open dialogue on the strategy chosen, e.g. eradication, herd immunity. There would be vaccination as soon as a safe and effective vaccine was available to distribute, initially to the highest risk citizens and key workers. Slide 6. The Office of National Statistics, the unsung heroes. The Office of National Statistics in the UK began a Covid-19 survey in April 2020. Every 2 weeks, 180,000 people are chosen at random, a throat swab taken, followed by CPR testing, sometimes blood samples. To date, 5.5 million results have been processed. The information is accurate, timely, and a continuous updated stream of information examining age, sex, geography, ethnicity, vaccine status, the emergence of new variants. Critical information can inform policy and decisions around vaccine rollout, vaccine duration, and effectiveness of vaccine take-up. Slide 7, the United Nations. Despite failures, deadlocks, angry disagreements, problems of funding, and the shortcomings of the blueberries, 2 cheers for the United Nations. It is better to have the United Nations in a global debating chamber than the secrets and lies disguised in nationalism and patriotism. Slide 8. The World Health Organization has been criticised, arguably slow to declare the pandemic, frustrated by Chinese secrecy. Yet it has provided steady leadership and insisted that the best strategy is to vaccinate every man, woman and child in the world. It has argued for patent rights to be waived and countries assisted to manufacture their own vaccines. Deaths and death rates by country should be standardized by age, sex, ethnicity and social class and collected in a standardized format to enable true comparisons between countries and their performance. Slide 9. This shows the distribution of world cases in March 2022, and in particular the darkest colours showing the worst problems, where the United States of America, South America and Europe have been particularly suffered badly. And death are at all points of the compass rich and poor countries, but on the whole the poor have had worse outcomes and suffered most. Slide 10. This in fact shows death rates around the world, slightly different to the cases around the world, and where the deaths have been more likely in the poorest countries. The rich countries which did badly had poor leadership, non-compliance with advice, reluctance to lockdown and too early reopening. There was political opportunism, possibly fake news. There was vociferous protests around inadequate preparation. There was denial and wrong information. There was protest about freedoms, work and security. There was a crucial lack of information in real time. There was distrust of vaccination, vaccine nationalism, and slow rollout of vaccine coverage. People did not trust their governments and were fearful. 11. Waves of disease. Covid-19 infections have spread through the UK since March 2020, while herd immunity has been slow and sporadic. People have been infected and ill despite an earlier infection. There have been waves linked to 3 main variants, Alpha, Delta and Omicron. 2 years on and still several thousand new infections are occurring daily. The virus is less pathogenic but remains highly infective with an R greater than 1. Waves of extra cases have occurred each time lockdown is lifted, schools and universities reopen and people return to work and travel on public transport. Celebrations and social events like Christmas or Easter have produced excess cases 2 or 3 weeks later. New variants, less susceptible to vaccines in current use, have also made for additional waves. The vaccines have reduced the impact, but the unvaccinated have been more susceptible. The virus is still active and still with us around the world. In the UK in early March 2020, at any time there were 2 to 2.5 million people with Covid-19 infection, 6 to 8,000 people in hospital, and 800 deaths a week. It has been recognised that younger people, 6 to 18, although usually having a mild illness, spread the disease easily. They find lockdowns, mask wearing and distancing more difficult, and increasingly are encouraged to be vaccinated. Slide 12, Waves of Disease 2. Infections predate notifications with an incubation period between 5 and 14 days, but principally 5 to 10 days. Virus mutations have different infectivity, incubation, and clinical footprint. The increase in R number, the number of people infected from an established case, rises above 1 some 2 weeks before the ensuing wave. Slide 13, Research and Development. Clinical research and development has indicated how much we had to learn and how much better we are at managing and treating as time has elapsed. The best packages of investigation, management, specific treatments, complications and prognosis are shared. Death rates have fallen, morbidity decreased, staff confident and properly protected by PPE and protocols. There are now specific treatments and many more in clinical trials. For example, ivermectin, possibly useful in prevention, IL-6 receptor blockers, monoclonal antibodies, convalescent plasma. There are some 10 vaccines available around the world. They are effective in preventing infection and modifying any COVID-19 infection. Maximum effectiveness using a 2 or 3 dose model is to use a different vaccine for each dose, promoting better and longer lasting protection.